Thank you, Barbara. Thank you all for getting up so early, and we have another wonderful day in Chicago today for you. The first speaker of Medical Retina and Chorioretinal Vascular Disease Part 2 is Paul Chan, who will talk on anti-VEGF therapy for pediatric retina/ROP.
Great, thanks, Lee. And thank you to the organizing committee for having me speak to you today about anti-VEGF therapy for pediatric retinal conditions and also specifically for ROP. These are my financial disclosures, none of which are related to the contents of this talk. As I mentioned, I will be discussing the off-label use of anti-VEGF for pediatric retina patients. Here we show the evolution of the management for retinopathy prematurity. And as we all know, we started with cryotherapy for peripheral ablation of the avascular retina, then shifting to laser. And then in 2006, we started to see an uptick of the use of anti-VEGF agents, such as bevacizumab, for the treatment of ROP. And then, of course, in 2011, we saw the BEAT-ROP study data published in the New England Journal of Medicine showing effectiveness for intravitreal anti-VEGF therapy for zone 1, stage 3 with plus. And then more recently, we've had RAINBOW, which looked at ranibizumab for the management of ROP compared to laser. And then in 2022, we saw the published results of FIREFLY showing us 0.4 milligrams of aflibercept compared to laser photocoagulation. And although aflibercept did not show non-inferiority compared to laser, it did show that it was effective, so 85.5% of the time compared to 82.1% for the primary outcomes. And I think very importantly, the study also showed us data on pharmacokinetics, showing us that free aflibercept declined to values that were very low at the 8-week time point. And in 2023, and I think Wiley Chambers is here, aflibercept did receive FDA approval for the use of treatment for ROP. Okay, so that was a very exciting time for us who managed this condition. Now there's FIREFLY Next. This study is then looking at the 5-year data, looking at longer-term outcomes in these patients, looking at local outcomes as well as neurodevelopment and systemic outcomes for these patients. And the early data has been promising, showing at 2 years you have low unfavorable structural outcomes, low recurrence of disease, and low complications in these patients. Most eyes, both in the laser group and also in the anti-VEGF group, were able to fix and follow a 5-centimeter toy, and no surprise, myopia was less common in the aflibercept group. Overall, the study is showing us, at least at this 2-year time point, that aflibercept is effective and well tolerated for these patients. No retinal detachment was observed. Disease reactivation was rare. And I think this is very important. No patient received treatment later than 50 weeks of age. And the myopia was less in aflibercept patients. Systemically, they did not notice any treatment-specific adverse events on growth or neurodevelopment. And we look forward to the 5-year data being presented in 2026. All right, so with all of this, we now have an FDA-approved agent for ROP. And I think many of us are starting to consider to use it. Some are using it. But we do have to think about issues around reactivation and persistent avascular retina as we start to see more use of anti-VEGF and ROP. This is a patient of ours who was treated with anti-VEGF. You can see here pre-treatment, the posterior nature of disease, zone 1, stage 3 with plus disease, and then post-treatment, and we're seeing this more often now, many weeks later, this is over 10 weeks later, you can see that there's normal vascular growth of the retina past the initial ridge, but you do your fluorescein angiogram, you can see the large extent of avascular retina from the vascularized retina to the aura. So this brings up also the issues around, do we need fluorescein angiography as we think about managing these patients in the long term? ICROP3 has given us a lot of information around the definitions of ROP reactivation and also avascular retina, and here you can see the definitions. This is relevant as we think about our clinical trials going forward, understanding how to manage reactivation and also persisting avascular retina. DRCR and PDIC have been doing a significant amount of work on low dose or very low dose bevacizumab. So this brings up the question of, well, if we decrease the dose of anti-VEGF, will this lower the rate of reactivation or even persisting avascular retina in the long term? This initial study did not show that that was the case, but I think we'll learn more as we go forward. Two other conditions that will benefit from anti-VEGF are aggressive ROP and aggressive posterior vitreoretinopathy, which is sort of a fever-type variant. These conditions do benefit from early treatment, but also in APVR may benefit from laser, anti-VEGF, and early vitrectomy. Coats disease and fever also benefit from anti-VEGF treatment, although laser is very important for their management, so we have to consider that. And now, since we do have an FDA-approved agent, aflibercept, for the management of a pediatric retinal condition, the question is, going forward, this patient with choroidal neovascularization, for example, which agent do we use? Right? It's still off-label if we use aflibercept, but it is approved for a pediatric indication. This patient did have aflibercept and showed good improvement and good functional and visual improvement. Very importantly, when we think about risk management, OMIC has a number of resources regarding informed consent for parents, thinking about off-label use, and a number of educational materials at the ROP safety net. So in summary, anti-VEGF agents have been shown to be effective in pediatric retina conditions, specifically ROP, aggressive ROP, coats, fever, APVR, and choroidal neovascularization. Informed consent is critical when discussing this with the families, educating them to make sure they make the best decisions for their children. And I think as a profession, we need to continue our discussion around guidelines for treatment and also how do we follow up these patients going forward. Thank you very much.
Thank you, Paul. The next speaker will be Glenn Yu, speaking on suprachoroidal drug delivery in the real world.
Thank you. So today I'm going to be talking about suprachoroidal delivery. Here are my disclosures. Of note, I am a consultant for several companies that have assets in suprachoroidal delivery. Suprachoroidal space is a potential space that historically we think about as only visible in certain pathologic conditions. But on enhanced depth imaging, or EDI OCT, we actually now know that even in some normal patients, you can sometimes see this suprachoroidal space appearing as a hyperreflective band between the choroid and the sclera. Suprachoroidal space could be accessible using microneedles that are just long enough to penetrate the sclera without perforating into the vitreous cavity. It can also be accessed by microcatheterization. Now, imaging studies have shown that actually both on anterior segment OCT as well as posterior segment OCT, that you can see this suprachoroidal space expand after injections. This is images from the patient from the Tanzanite study, which randomized patients to suprachoroidal triamcinolone in patients with retinal vein occlusions with macular edema. And you can see a measurable and statistically significant increase in that space out to 3 months after an injection. Now, suprachoroidal triamcinolone has been evaluated across a variety of conditions, but most relevant to many of us is the phase 3 Peachtree study, which looked at patients with uveitic CME and randomized patients to suprachoroidal triamcinolone versus sham given at weeks 0 and 12. And you can see both visual acuity gains as well as low rates of rescue injections needed. But how does this hold up in the real world? So to do this, we looked at the IRIS registry linked to open source insurance claims data, and we looked at patients who are adults with a diagnosis of non-uveitic CME, or non-infectious uveitic macular edema, who received a suprachoroidal triamcinolone injection. We looked at patients using the index date as their first suprachoroidal triamcinolone injection and looked at time to rescue of any other steroid injection or topical steroids with a follow-up of minimum of 6 months. And we ended up with about 785 patients who fulfilled these inclusion criteria. Now, interestingly, if you look at the study demographics, many of these are very similar to what was in the Peachtree study, but interestingly, about 40% of patients actually have some history of glaucoma or ocular hypertension, suggesting some level of comfort with providers, given the fact that suprachoroidal space theoretically has this idea of sequestering the drug away from anterior segment and having lower risk in glaucoma patients. We also know that about a third of these patients had some prior corticosteroid use. Now, if you look at the Kaplan-Meier curve, comparing the IRIS data versus the Peachtree trial, it actually looks pretty good. Actually, about 88% of eyes in the real-world setting who received a suprachoroidal triamcinolone did not require a rescue injection. And in comparison, Peachtree was similar, and even though in the Peachtree study, everybody actually got a suprachoroidal injection at week 12. If you look at the actual breakdown of those who are getting these rescue injections, about half of them were another repeat suprachoroidal triamcinolone, and then the other half is roughly divided between intravitreal triamcinolone, dexamethasone implants, as well as subtenon triamcinolone. Now, if you look at time to rescue of any steroid, that includes topical steroids, that number does go down to roughly 75%, not needing rescue, but that's still a pretty good rate at week 24. So talking about if you are going to be doing this in the clinic, if you haven't done one already, it's very important to have good patient selection. You know, patients who are highly myopic or have scleral thinning, you might want to avoid. These patients were not in the trial. Patients with glaucoma with hardware in the area, you might not want to be your first patient. Expectation setting is important. Patients should know that you get this sensation of like a pressure wave or some call an ice cream headache. It's definitely going to take longer, and you might need to switch to a different location or sometimes even to a different needle. There are 2 needles that come with the kit. And patient preparation, I really actually like having the patient having head support just because it's going to take some time. I prefer topical over subconjunctival anesthesia, and a lit speculum is also helpful to make sure they keep their eyes open. The kit comes with 2 needle lengths, 900 and 1100 microns. Generally, we prefer temporal locations, and a majority of patients are able to get the first injection using the 900 micron length. We've published several articles along with many of my colleagues here on the technique, and it's very important to maintain perpendicularity because it minimizes the distance the needle have to travel through the sclera. You need to ensure firm contact, dimpling throughout the injection, and do it very, very slowly, 5 to 10 seconds. Otherwise, it could trigger quite a lot of discomfort in the patient. Now, I want to think about suprachoroidal injections not just for the delivery of steroids, but as a platform for a variety of different programs, including tyrosine kinase inhibitors and AAV gene therapy. And for example, in the Odyssey trial, which randomized the CLS-AX, which is an axitinib suprachoroidally versus aflibercept, many of these patients in preliminary results show stability in visual acuity and anatomic control. So in conclusion, suprachoroidal microinjectors enable targeted delivery to the suprachoroidal space. The triamcinolone acetonide given suprachoroidally is FDA approved for uveitic macular edema. Durability of suprachoroidal triamcinolone in real-world studies appears to be comparable to the phase 3 trial results, with about 12% needing subsequent steroids within 24 weeks. And optimal technique for suprachoroidal injection should be perpendicular, dimpling the sclera, and performed slowly. Thank you.
Our next speaker will be Mary Hartnett, who's going to speak on clinical trials testing anti-angiogenic agents change our thinking about the pathogenesis of disease.
Thank you, Lee, and thank you to the organizers and for the opportunity to speak to you today. I'm Emmy Hartnett from Byers Eye Institute of Stanford University, and here are my financial disclosures. So when determining the best treatment strategy for patients, we review evidence from multiple sources. Basic science provides opportunities to study mechanism of disease. Clinical trials are gold standard, but are limited in determining mechanisms. So it's important to review data in an iterative process of bench to bedside and then back again in order to get to the truth. And I'm going to describe 3 areas where angiogenic treatments had surprises that led us to greater discovery. Multiple processes constitute angiogenesis when we think of treatment for diseases. We may wish to inhibit endothelial proliferation with an inhibitor, but find an unexpected outcome from inhibiting permeability, assembly of vessels, or even endothelial or other cell survival. And there are many factors that increase angiogenesis, but the most known treatments to date involve anti-VEGF and Ang2 inhibitors. Now, the first example that I'll present is anti-VEGF that was used to treat macular edema. In central retinal vein occlusion, the natural history prior to anti-VEGF treatment was that 15% of non-ischemic CRVO became ischemic at 4 months with neovascularization and 34% at 3 years. Visual acuity was rarely better than 20/40. With anti-VEGF treatments to treat macular edema, ischemic CRVO with neovascularization fell to 0 to 4%, and vision improved. And this was somewhat surprising. But it led to a hypothesis then that anti-VEGF reduced resistance and improved blood flow, perhaps improving oxygenation. Studies also showed that reduction in macular thickness and volume on OCT as indicators of reduced macular edema was associated with improved vision. However, this did not always occur and may be related to retinal thinning from infarcted capillaries that mask the reduced thickness. In diabetic macular edema, reduced thickness and volume on OCT were not always associated with improved vision, and it was postulated that this was from inflammation. Yet studies with combination therapy of steroids and anti-VEGF or sequentially have not always yielded improvement beyond either treatment alone. More study is needed, but new therapies for inflammatory cytokines or other pathologic mechanisms bring hope. Now, a second example is the unexpected finding that inhibiting an angiogenic pathway actually increased angiogenesis. In this case, by extending developmental angiogenesis in premature infants whose retinal vascular development is incomplete when they are born. In experimental studies using representative models of retinopathy of prematurity, too much signaling through VEGF receptor 2 and endothelial cells caused them to have disordered cell divisions and to grow on top of one another, potentially into the vitreous. Regulation of signaling allowed ordered divisions and extended growth into the periphery as more linear vessels. In a carefully designed retrospective non-randomized treatment-controlled study, evidence supported the work from the laboratory. Infants consented for anti-VEGF rather than laser for type 1 ROP had greater extension of vascularization compared to the natural history in a prematurity matched group of infants who had less severe ROP. High-quality images were obtained and analyzed by a masked analyst. So here are the data showing the greater extension of vascularization into the periphery in the treatment group on the right compared to the control group at follow-up up to 2 months after injection. This will need to be confirmed in larger and prospective studies, but is exciting and offers hope for future studies to target the pathologic signaling at the VEGF receptor level in endothelial cells without affecting physiologic angiogenesis. Now, in this study, infants were small enough to have imaging without anesthesia and while they were in the hospital. So the study did not address persistent avascular retina, which will require additional study. More work is needed in both basic and clinical research to target the pathologic and allow beneficial signaling of VEGF receptor 2. Third, endothelial cells, glia, and neurons have been described as the neurovascular unit and interplay with immune cells and disease. You'll see how closely opposed these cells are in this section from an oxygen-induced retinopathy model showing endothelial vessels in red and neurons in green and blue. On the far right, red Mueller cells and RPE are labeled for reference. In diabetic retinopathy, disorganized retinal inner layers, or DRIL, is associated with vision loss. Anti-VEGF treatment can reduce the blur seen on OCT here and has been associated with improved vision. However, it was only through proteomic studies that we now have a hypothesis that suggests that glial dysfunction may be involved. Now, on the other hand, removing too much VEGF can be damaging to Mueller cells in oxygen-induced retinopathy used to model retinopathy of prematurity, and allowing some of the VEGF forms access to the retinal neurons avoided the damage and the later dysfunction. So in conclusion, clinical trials guide treatment decisions, but also provide new hypotheses for future clinical and basic investigations. The sense of discovery can be exciting and requires support from collaborative work among clinicians, scientists, and clinician scientists. With large databases, there are opportunities to refine and create new hypotheses. This is important for the best care and management of our patients. Thank you.
So our next speaker will be Sophie Bakri, who is going to talk about evidence-based treatment of central serous retinopathy, chorioretinopathy.
Good morning. These are my financial disclosures. So we all see patients with central serous retinopathy, and very important to go through the risk factors, many of which have been identified with large database studies. So this is a 50-year-old patient with 20/30 vision who had received aflibercept elsewhere for possible CNV versus CSR. And here you see the leakage on the fluorescein angiogram. And as we went through risk factors, we went through the supplements that this patient was on. And as you can see, there were really a lot of supplements. And so my recommendation is that she stop the supplements, reduce her stress, and I made her aware of her type A personality, especially being that she was an Olympic athlete. A month later, her vision was 20/20 without treatment, and that remained for at least 1 year. So I show this because with the excitement of looking for new treatments, it is important to remember that acute CSR is a self-limited disease. CSR tends to be bilateral, and it's very important to have randomized controlled trials to assess the response. So the first question is, does anti-VEGF therapy work for CSR? So this is a meta-analysis and review that showed that there was no difference between CSR patients treated with bevacizumab versus control. Another meta-analysis, here you have 4 prospective randomized controlled trials, showed no difference in terms of CSR, visual acuity, acute or chronic, and no difference in OCT, except for perhaps a slight signal in the chronic cases. So what about low-fluence PDT versus ranibizumab? This is a 1-year randomized trial. Here you can see the visual acuity in OCT, and the PDT group performed better on both fronts. And there were more patients who had complete subretinal fluid resolution in the PDT group, so approximately 90% versus 35% in the ranibizumab group. So there's no evidence that anti-VEGF therapy is of benefit for acute or chronic CSR. However, anti-VEGF is very beneficial for CNV associated with CSR. So what about PDT? What is the evidence and what parameters should I use? So half-dose PDT for acute CSR versus a placebo study. And here you can see at 3 months and 12 months, you can see the results that the PDT group performed better. When looking at standard fluence versus low fluence in a clinical trial that is non-randomized, here you see 42 patients. And there was no difference between the groups at any time point in terms of vision or OCT thickness. But there was a difference in choriocapillaris perfusion. When you look at high grades of non-perfusion, that was higher in the standard fluence group. And so this is what it looks like. If you look at the bottom right, you can see the choroidal hypoperfusion occurring in late phase ICG in the standard fluence group. But if you compare to the reduced fluence PDT group, really there is no choroidal hypoperfusion. So when do I consider full fluence PDT? So this is a patient with 20/30 vision in both eyes, had a central scotoma for 1 year, history of steroid injections and inhalers, many previous treatments tried, and here you see the hot spot on fluorescein angiography and the fluid on OCT. So this is a patient in whom I performed full fluence PDT. It is actually either juxtafoveal or extrafoveal, which helps, and 20/20 vision 3 months later maintained for several years. The Macular Society did a collaborative retrospective study for PDT, and that showed that that normal fluence PDT was used in about half of patients, and half fluence PDT in the other half. The number of PDT treatments was 1 in 89%, with fluid resolving in 81%. In terms of long-term follow-up, another study showed that 13% of eyes had a subretinal fluid recurrence, and only 4% were within 1 year. So what about micropulse laser? So this is the PLACE trial, which compared half-dose PDT versus high-density subthreshold micropulse laser, and it showed that the PDT treated patients had a significantly higher increase in best-corrected visual acuity. Mineralocorticoid antagonists have been used because an animal study showed that activation of the mineralocorticoid receptors can lead to an increase in choroidal hyperpermeability, and so many investigators have since tried mineralocorticoid antagonists. A comparison of the short-term efficacy between oral spironolactone and PDT was done. 41 patients, and you can see that the vision improved significantly in both groups, and there was a significant decrease in subretinal fluid in both groups. But the change in choroidal thickness was only significant for the PDT groups at the 1 and 3 month time points. There are many side effects with spironolactone. In 2002, eplerenone was approved, which is 40 times less potent and designed to reduce hormonal effects. One study showed subretinal fluid resolution in 23% of eplerenone patients versus 31% of placebo, and concluded that eplerenone was not found to be superior to placebo in eyes with chronic central serous retinopathy. The Vicky trial randomized patients to either eplerenone or placebo, and the primary outcome was vision at 12 months, and found that eplerenone was not superior to placebo. And here you see the results both in terms of vision and OCT thickness. The Spectra trial randomized patients to half-dose PDT versus eplerenone, and again found a significant subretinal fluid resolution at 3 months, 78% in the PDT group versus 17% in the eplerenone group. Much less systemic side effects in the PDT group. So there are other reported treatments, which I didn't dwell on this talk because they are non-controlled studies or case reports, and the reports are very early. My preference, based on current evidence, is that I look for risk factors and use PDT when treatment is needed, reduced fluence if there's foveal involvement, and the reason is that it's a local treatment with a long-term effect and really no systemic side effects. And I just want to end discussing systemic corticosteroid use after CSR. We know we have to discontinue and recommend discontinuation of steroids, but is this happening in clinical practice? So we did a Truven claims database where patients were diagnosed with CSR with an eye care provider, and we found that many patients continued to be prescribed steroids even after the CSR diagnosis. CSR patients showed a longer median time to steroid initiation after diagnosis and lower odds of receiving steroids within 6 months. But by 2 years, the odds of receiving a steroid prescription were approximately 25% higher in CSR patients compared to those without CSR. So despite the evidence that we have, many eye care providers and other providers continue to prescribe steroids, most commonly a 1-month oral prednisone, and we need more collaboration between physicians. So to summarize, in CSR, we carefully assess the risk factors. Currently, PDT has the best available evidence. We use anti-VEGF for CNV, and trials showed no benefit of eplerenone. Thank you very much.
So our next speaker will be Barry Kuppermann, talking on neuroprotection and neuroenhancement for dry AMD.
Thank you, Lee, and to the meeting organizers. You've done a great job. Talking about neuroprotection and neuroenhancement, a topic that's very exciting, particularly the neuroenhancement part as we move forward, financial disclosures. I'm a consultant to a variety of companies involved in this space. So where we are now, sort of, is neuroprotection with our treatments, complement inhibition for geographic atrophy. We're able to reduce the rate of cell death. We're not stopping the disease. We're slowing it down. Photoreceptors and RB cells are still dying. The future, and what we're going to present to you today, is neuroenhancement, which improves function of surviving cells, damaged but not dead cells. That would be neuroregeneration. We're not there yet. And improving retinal function with a chance for improvement in visual acuity. Again, dry AMD is still a huge unmet need. We're focusing on GA, and I'm going to show you both GA and dry AMD studies, but several drugs in development show promising results in reversing vision loss, improving vision in dry AMD, and also an important message, easy zone attenuation. It's now both usable to enrich your target population in clinical trials. If they have a relatively intact easy zone, those are good candidates for clinical trials. And the FDA now allows easy zone attenuation as a surrogate, as a validated surrogate endpoint for clinical trials. So let's get looking at it. AMD is characterized by mitochondrial defects. The first two compounds I'm going to share with you have mitochondrial effects. And so again, rizutigimab preserves mitochondrial structure in RP cells under stress. This is cell culture work by Glenn Jaffe at Duke. And there was a clinical trial done with 2 injections 3 months apart of this compound rizutigimab in dry AMD. The primary efficacy endpoint was improvement of vision by 8 letters, and 48% of patients improved by 8 letters, meeting the primary efficacy endpoint. 32% improved by 10 letters or more, and 20% improved by 15 letters or more. And what characterized those that improved? Enhanced ellipsoid integrity, greater outer retinal thickness, and decreased GA. This is what a responder looks like on the left and a non-responder in that trial on the right. And at Cole Eye Institute and Duke Reading Center, they independently looked at those responders as defined by 8 letters gain, and they both saw that more preserve the photoreceptors, the better response to this drug, and it would be true of other drugs as well. If there's a 30 micron or more photoreceptor layer, or increase the responder rate by 40%. That's who you want to enroll in these trials. Moving on to the next one, elamipretide, proprietary to Stealth Therapeutics, binds cardiolipin to restore mitochondrial structure and function. The cristae become more structurally intact, and there's better bioenergetics. What they showed in their trial, which was a subcutaneous injection daily, is decreased rate of ellipsoid zone attenuation, as shown here, 43% reduction, and a shift to the right in low luminance best corrected visual acuity. And if you looked at those that had improvement in visual function, those were patients with healthier photoreceptors at baseline, again as shown in the rizutigimab trial, and they're thinking that this may improve the bioenergetics, making these photoreceptors healthier, they have better energy, they can see better. Moving on to yet another interesting new mechanism of action. We know that macrophage overactivation and complement dysregulation is important in geographic atrophy. The macrophages become activated into either the inflammatory M1 or the angiogenic M2. The goal is to turn them into repolarize them to the resolution state where the inflammatory cascade is quenched. And this is via Siglec receptors, which control the immune response. They're receptors expressed on all immune cells and are a primary mechanism of immune resolution. And a company, Avicida, has a drug proprietary called AVD-104, which has a dual mechanism of action. It binds the Siglec receptors to repolarize inflammatory microglia, and it also binds the CFH, complement factor H, to stop amplification of complement factor C3. You can see the compound there. It's a structure. It's 100 nanometers in size with a 20 kilodalton weight. They've completed a phase 2A trial of just 30 patients, but a dose escalation 12 in lower dose that would turn out to be subtherapeutic, and another 9 and 9, 18 in the higher doses, which turned out to be more therapeutic in patients with GA. And you can see in these curves here, the two upper curves are the ones that show continued progression of GA at a more rapid rate, the low dose, and the higher dose, 1 and 3 milligram, had a slowed rate of progression. When you compared the high dose groups to fellow eye, they showed a reduction, a comparison reduction in one. This is a 1 injection over 3 months, just a 3-month trial, but a 48% reduction, and importantly, vision improved in these patients. Somehow the junctional zone, those photoreceptors are functioning better. You can see in the higher dose improvement of vision on the curves on the right, and the lower doses without an improvement in vision. Moving on now to another mechanism in the complement cascade, but looking at C1q, it's thought to drive photoreceptor synapse and cell loss and neuroinflammation. Loss of synapse is equal to loss of neuronal function. A company, Annexon, has a product, ANX007, which inhibits C1q and all damaging components of this classical pathway and protects synapses from elimination. And again, you can see here in this trial, there was a visual acuity benefit, a reduction in the loss, in 15-letter loss. Again, first known significant preservation of vision in GA, somewhat different from what we've seen from the C3 and C5 trials. And it's dose dependent. What it didn't show was a difference in GA, so that's concerning. But if you look over time in the second 6 months of the first year, there seemed to be a separation of the curve there, some impact there. And if you look at ellipsoid zone, both total loss and EZ zone attenuation, there is an effect seen there, so that's an anatomic effect that's seen in association with the visual benefit. Again, finally, ONL, a small company that's got a unique and differentiated mechanism of action. It focuses on FAST. FAST is an upstream activator of cell death and pathways and inflammation, and when you target that FAST, it prevents activation of downstream death pathways, the apoptotic pathway. Inflammatory cascade is also targeted, which accelerates cell death in tissue. So by targeting FAST, as in ONL 1204, their product targets FAST upstream of death signaling and inflammatory pathways, including complement. They've got a small trial, but again, component 1 was a single injection, component 2 was 2 injections, and what they showed in both of these, not only effect on GA growth, but improvement in vision, a change in vision. So again, we're able to have some visual benefit. Here you see after the 2 injections in the component 2, they're now going to go ahead with a phase 2 trial as well. So again, in conclusion, neuroprotection, neuroenhancement, we're really entering the era of neuroenhancement. We're in the era of neuroprotection with our current complement inhibitors, but restoration of functional vision seems to be achievable in patients with dry AMD who have somewhat anatomic integrity. Having a somewhat intact ellipsoid zone are the patients you want to target, and these new approaches include looking at mitochondrial stabilizing drugs, macrophage repolarization, synaptic protection, and fast ligand binding, suggesting that early treatment of dry AMD is an appropriate target to reverse vision loss. And again, it's important when you design the clinical trials to establish minimum thresholds of EZ zone thickness, because those are the patients that can benefit, and reduction of ellipsoid zone attenuation is an accepted anatomic endpoint, surrogate endpoint for clinical trials. That should be how these trials are designed. Thank you so much for your attention.
The next speaker, Jacque Duncan, is going to tell us why do we still have so few treatments for retinal degenerations, and where do we go from here?
Good morning. I'd like to thank the organizers for this opportunity to discuss with you why we still have so few treatments for patients with retinal degenerations and where we should go from here. These are my financial disclosures. The field of ophthalmology and retinal degenerations in particular celebrated a major victory with the first FDA-approved treatment in all of medicine for gene replacement of a genetic inherited disease with the approval of voretigene neparvovec. This was the first gene therapy to treat a genetic disease that received regulatory approval. The investigators developed a novel outcome measure that demonstrated improvement in treated children as young as age 3, which was a novel way to demonstrate that this treatment was effective and led to its approval. But that was in 2017, almost a decade ago. Since then, dozens of gene therapies have been used to treat hundreds of patients with genetic diseases and studied in clinical trials. Mostly, these have been found to be safe, but none have met their primary endpoints yet, although a number of clinical trials are still ongoing. This slide from Alicia Kemble and Rusty Kelly of the Foundation Fighting Blindness Retinal Degeneration Fund, RD Fund, shows the landscape of clinical trials for patients with inherited retinal degenerations. The diseases being treated are shown in the innermost circle. And you can see that the only treatment to receive FDA approval to date is voretigene neparvovec. The next ring out shows a number of companies that have compounds in phase 2-3 studies for treatments of inherited retinal degenerations. The subsequent ring shows trials that are in phases 1 or 2. And you can see a truly large number of companies which are developing preclinical stages of treatments for inherited retinal degenerations. Well, the real goal of treatments for patients with vision loss would be vision restoration. And there are a couple of approaches to restore vision in people who have lost their photoreceptors due to inherited retinal degenerations. Optogenetics is an approach to deliver light-sensing proteins to cells that usually don't respond to light. Another approach would be to use prosthetics to deliver electrical impulses that will then stimulate visual pathways. Both of these approaches have a number of challenges, including being having low sensitivity, requiring bright light to stimulate the approaches, having a limited dynamic range, sometimes being sensitive only to specific wavelengths of light, which then requires the user to wear goggles that will deliver the right intensity and wavelength of light to stimulate the compound or the prosthetic. And either with hardware or gene-specific treatments, it's very hard to upgrade should a future improvement become available in the future. Well, inherited retinal degenerations are rare, which makes it difficult to develop gene-specific therapies. It's challenging to find enough patients to sufficiently power a clinical trial that will demonstrate a treatment is safe and effective. In addition, about 30% of people don't know what the genetic cause of their disease is, even with the most comprehensive and sophisticated genetic testing available. So a number of non-specific therapeutics have been investigated based on mechanisms of photoreceptor degeneration, and many of those are shown on this slide that are currently in clinical trials enrolling patients. So how do we improve the likelihood that clinical trials will meet their primary endpoint and demonstrate a treatment is safe and effective enough to deserve and warrant regulatory approval? Well, we take lessons from natural history studies that can show us which measures are likely to change over the course of a treatment trial. A group called the Regulatory Endpoints and Trial Design for IRDs, or RETI Working Group, is a consortium of clinical experts who see patients with inherited retinal degenerations, collaborating with regulatory agencies to inform clinical trial design. We began by analyzing data from a 4-year natural history study of patients with USH2A-related rod cone degeneration, the RUSH2A study, which taught us that both visual acuity and ellipsoid zone area have major limitations and serious flaws. Visual acuity in this study of over 100 patients with USH2A-related rod cone degeneration changed on average by about 1 letter per year, and only 2 patients demonstrated at least 3 lines of change over 4 years of a natural history study. Similarly, ellipsoid zone area had a major floor effect, where 2/3 of the patients that were enrolled had too little remaining ellipsoid zone area to demonstrate change over 4 years. This means if the ellipsoid zone area is chosen as a primary outcome measure, the patients that should be eligible to participate should have at least 3 square millimeters of area remaining at baseline, which limits the number of patients that are eligible to participate and may limit the generalizability of the compound once it's approved. So, in USH2A-related RP, we learned that visual acuity is too slow, changing by only 1 letter per year. And EZ area is too low. There's a significant floor effect in about 2/3 of people that we would want to enroll in our clinical trial. This means we need to look for novel outcome measures, including things like full field stimulus threshold that measures the most sensitive part of the retina's ability to respond to vision, even in eyes with relatively early rod cone degeneration. And by focusing our attention on locations in the visual field that are most likely to demonstrate change over time, using an approach called the functional transition points analysis, we may be able to shorten trial duration and improve the likelihood that treatments will meet their primary endpoint. And the results of this work were published in a peer-reviewed publication last week. So why do we still have so few treatments for retinal degenerations, and where should we go from here? Well, the success of RPE65 therapy really inspired multiple trials, but it set a very high bar of visual improvement, which is aspirational and may be unrealistic for many treatments. Natural history studies allow us to identify outcome measures that are likely to change significantly over the course of a trial. And we are ready to disseminate the findings learned from natural history studies that can be shared with regulatory agencies and industry sponsors to inform and improve trial design so that we will have more treatments tomorrow than we have today. Thank you.
So our next speaker will be Elliott Sohn, who's going to talk on, Pentosan polysulfate maculopathy. It's the drug, not interstitial cystitis.
Good morning. Thank you to the organizers for this opportunity to present. Let's start with a case here. We have a 55-year-old woman who was referred to the University of Iowa for evaluation of wet AMD. In 2015, you can see her vision here was excellent, but had these changes, hyper and hypopigmented changes around the fovea with corresponding findings on the OCT. Now, this is a little bit early to have AMD and this many findings, but not impossible. But still, we're at the University of Iowa, so we did genetic testing for this patient. We tested for pattern dystrophy, Stargardt disease, and with 2 deaf siblings and 1 with diabetes also from mid. Those, of course, were negative. 6 years later, this is her. Now vision starting to drop. So you can see the widespread area of decreased autofluorescence corresponding to the OCT changes. And by now, of course, 3 years after the discovery, we found that she's on Pentosan polysulfate for interstitial cystitis for 21 years with a cumulative dosage of almost 3,000 grams. What is interstitial cystitis? Also known as bladder pain syndrome. This is a difficult condition to have. Chronic bladder pain, pelvic pain with increased urinary frequency and urgency. It's associated with poor quality of life. We've had some patients who even have suicidal ideations with this disorder. The median age at onset is 40 years old, and 3 to 8 million women in the US alone have this condition. It's due to multiple different things, but we know there's injury to the glycosaminoglycan, the GAG layer, allowing damage via increased permeability and pain, where the urine is now able to access these nerve endings in the bladder wall and cause this intense discomfort. So Pentosan polysulfate, trade name Elmeron, is the only FDA-approved drug that's an oral medication to treat this condition. It's been used since the 1980s, off-label. It has a couple different mechanisms of action that are useful to consider here. One is that it's a heparinase inhibitor, but it also is a GAG mimicker that replaces the deficient layer in the bladder urothelium of the IC patients. So then what you see here is that you have a blockage of the urine being able to access these nerve endings. And of course, there was a black box labeled by the FDA in 2020. So why do we think Pentosan causes maculopathy? Well, since Neeraj Jain and colleagues published this important finding in 2018, you can see in the upper left a patient with relatively dramatic changes with increased and decreased hypoautofluorescence, best seen on autofluorescence, but you can also see on fundus exam as well. In our review paper 2 years ago, you can see some range of findings, even patient having choroidal neovascular membrane that responded well to anti-VEGF therapy. Now in OCT, you can see various changes, but one thing that's unique, you can see subretinal drusenoid deposits. They're like these deposits, they're like drusen, but instead they're over the RPE instead of underneath the RPE like you see with traditional drusen. So there's about 100 publications describing this association. Just a small highlight of some of these with an N of over 20. You can see at the bottom here that the duration of exposure and the cumulative dose in grams are very important. 8.8 years being the lowest out of this when I'm showing up here, and also cumulative dosage of 915 grams. But there have been reports of patients with even less duration and dosage who have had this association and the maculopathy. So in order to establish causation, there's a couple things we use, but Bradford-Hill criteria is a classic thing that can be used to really establish this. So one is the strength of association, consistency, reproducibility, specificity, temporality, seeing a dose-response relationship, so I've already described some of those things, Biologic plausibility, having coherence, does this make sense? Experiment and analogy. So what are some controlled studies suggesting biologic plausibility that we can look to here? Well, in heparinase knockout mice, so these are mice deficient in heparinase compared to controls, this is basically simulating the action of Pentosan, which inhibits heparinase. What you see here on the left is a wild-type mice. On the right is a heparinase deficient mouse, and you can see that over time there's pretty intense retinal and really severe RPE folds and changes that are happening here with attached RPE cells. All right, why are we looking at mouse histology slides at Academy? You're getting sleepy right now, I know. This is my 9-month-old, so sorry to do that, but just please bear with me for one more slide here. So this year, Neuroenhancement and the Emory group published this paper where they fed mice high-dose Pentosan for 14 months compared to control mice. What did they find? You can see that the photoreceptor layer had decreased outer segment thickness length in those mice given the Pentosan compared to controls. This corresponded to ERG changes as well as RPE disruption in only the mice given Pentosan. At the University of Iowa, we've looked at mice with and without interstitial cystitis given Pentosan and seen photoreceptor layer thinning in both of those groups on OCT. All right, way too many mouse slides. I'm sorry about that. Let's look at what about humans? What do we see in humans? It's hard to do because it's not a really controlled population. We do have some data, though. So Judy Kim and her colleagues did a trinetic search of nearly 70 million patients in the U.S. using multiple retinopathy codes. They had 88,000 women without interstitial cystitis and 22,000 women with IC, with varying lengths of PPS, Pentosan, and also not being on Pentosan at all. What you can see is this nice Kaplan-Meier survival curve, and you can see that those on the highest or longest duration of Pentosan really had the lowest amount of survival probability. In press and ophthalmology right now, the first large-scale study is being published of maculopathy seen in a non-Caucasian population. Over 300,000 Korean patients were studied with IC. Interestingly, 41% were men, and the average cumulative dose was only 41 grams, so very low, with the max being 1350 grams. But even with this small dose, relatively small dose, you still see an increased incidence of maculopathy in those on Pentosan despite this lower dosage. Okay, so let's go back and look at our Bradford Hill criteria. So, strength of association. We know that the prevalence of retinal changes is notably higher in those receiving Pentosan compared to non-users. We've seen this in multiple cohorts now, not just of different independent institutions, but also now patients of different ethnic backgrounds. And we know that this has distinctive, recognizable clinical features that you can see in the clinic. The development occurs after prolonged Pentosan exposure and occurs in a dose-response fashion. We have animal studies suggesting biologic plausibility. PPS, Pentosan, is a GAG analog, and this is critical. We know it's found in RP and Bruch's membrane. So has plausibility. It makes sense. Drug-induced retinopathies are a well-recognized phenomenon. And again, looking at animal studies and human studies, even discontinuing Pentosan may slow the progression of the maculopathy, although the damage, unfortunately, is still there. We have analogous situations like Plaquenil we know cause renotoxic effects with similar presentations. Potentially the most damning thing, number 10, that's not listed on here, is that the company, the drug manufacturer Janssen, started rolling out payments quietly as settlements in October 2023. Thank you very much for your attention.